Good morning.
We're almost there into the afternoon.
Yeah. Well, before we start, comments or questions regarding any of the material that we've gone over so far? All right, make sure you know your Glasgow coma score. And understand when we do a rapid extrication and when we fully immobilize. So if you take a look at emergency extrication, basically these are life-threatening problems where we don't want to take a lot of time putting a kit sled on the patient or anything like that. Obviously, we need to secure the patient, stabilize them. Okay, trauma assessment. In trauma, obviously, we manually stabilize the cervical spine. I don't think there's anything there that's particularly earth-shattering. On breathing, we're back to the difference between respiratory failure and respiratory distress. And in failure, you're going to use a BVM. In respiratory distress, we give oxygen. How do you determine failure from a distress? In failure, either you have shallow respirations or you have a bradypnea. Obviously, in trauma, time equals life. And if there is more than one system involved, then we have a traumatic or obviously trauma situation. Yeah.
Can you go back 2 slides just for a split second?
Are you gonna send this? Can you
I'm
send
not
it?
going to send this out.
One more. Thank you.
Okay, if you try memorizing it, you're not gonna pass the trauma test. You gotta understand and critically think it out. So, know the difference. And we talked a little bit about the difference of respiratory distress and respiratory failure. And again, that's a big point on these examinations, when to ventilate and when to give oxygen. Are there any questions about distress versus failure? Seems to be a bit of.
I guess my only question is, in respiratory distress, would you ever really use a nasal cannula unless there's...
Yeah.
Like, I guess what
In
would you-
distress?
Yeah, in distress, like, what would, because you would really want to use the non-rebreather first, right? Always?
How about if they don't tolerate the non-rebreathing?
Okay, but I mean, more for the exam purposes, like, it's always, you would prefer to use the non-rebreather.
What's their PO2 level?
92.
The PO2 level
Oh.
determines what you're gonna use, right? If it's below 90, you go with a non-rebreather. If it's above 90 but below 94, you go with a nasal cannula. Okay, difference between venous, arterial, and capillary bleeding. And venous bleeding is a steady flow of a dark burgundy blood. Arterial is a pulsation of bright red blood. And capillary bleeding is basically the oozing, it's a typical owie. What should you do? We start with direct pressure. If direct pressure is not appropriate, you can either pack the wound or use a tourniquet. Pressure points and elevation are no longer considered treatment options for soft tissue wounds. And what about blood thinners? What should you know about those?
If you're on blood thinners,
then you really need to put a lot of pressure on the wound, pack it, and if you can't control it, consider using a tourniquet. Signs and symptoms of shock. The biggest difference between compensated and decompensated is the blood pressure. In compensated shock, blood pressure is reasonably normal, maybe slightly elevated due to anxiety. Decompensated shock, blood pressure drops. If blood pressure drops, what happens to level of consciousness?
Irritability.
Well, they're irritable if they're in compensated shock. When they're in decompensated shock, it's past irritability. They're not going to be oriented because they're not getting enough blood to their brain. And remember, the vital sign that is the last to change is going to be blood pressure. So know the difference between compensated and decompensated shock. Watch that blood pressure, watch the level of consciousness. Tell me about pediatrics and compensation. Yeah, they compensate to the point of death, and they have very little, if any, decompensatory period. If we do look at shock, there is one flavor of shock that usually results or may result in warm, pink, dry skin.
Neurogenic.
You got it, neurogenic. We would normally expect to see pale, cool, clammy skin in all the other forms of shock. And treatment for compensated and decompensated shock is exactly the same. And our big issue with shock is where is shock best treated? In the field, in the emergency department, or in surgery?
Field.
Nope.
Surgery.
Emphasis of care in shock should be surgery. Okay, that's why we don't stay on scene for a very long period of time, because ultimately, if they're bleeding out, is there anything on scene that you can do to replace the blood?
Nope.
No, they need surgery. They need to be stabilized, blood transfusion, and obviously repair the surgical issue that's causing the shock. Flailed chest, signs and symptoms. Paradoxical respirations. What else? Some of it's just self-explanatory. What else?
Difficulty breathing.
Yeah, difficulty breathing, because ultimately you're not getting full bellows with the flailed segment. Pardon?
Wheezing?
No wheezing. No wheezing. No distension. How about pain and tenderness and difficulty breathing?
Will they be guarded, like usually?
You might, yeah. And treatment is basically give them oxygen. If they're in failure, use your BVM. Pericardial tamponade, signs and symptoms. They should have equal lung sounds. Good.
Chest pain.
It hurts. Jugular venous distension. There's another one.
Pulse pressure now.
Narrowing pulse pressure. next triad, besides narrowing the pulse pressure and jugular venous distension, we also have muffled heart tones.
If you have questions, let me know.
Tension pneumo? Pardon?
Pressure against the heart and lungs.
Correct, which is gonna cause what?
A low blood pressure.
Trachea distension.
Narrowing pulse pressure.
Narrowing, my bad.
Very good. What else?
Trachea distension.
Jugular venous distension. What else?
Unequal rise and fall of the chest.
Not necessarily an equal rise and fall, but unequal breath sounds.
Unequal, okay.
What else am I missing? Progressive dyspnea. Okay, and that one you should have gotten right off the bat, because are you gonna wait for the tracheal deviation that you didn't mention? Are you gonna wait for the jugular venous distension that you didn't mention? Or are you going to begin treating it as soon as you can? If you're waiting for all that pressure to be placed against the heart, causing your neck veins to stick out, your pulse pressure to narrow, you're waiting for the patient to be half dead. If you treat the patient based on a progression of dyspnea after you treat the pneumothorax, you're not gonna have all of those dynamics taking place, and your patient is more likely to survive. Remember that when you start getting tracheal deviation and you start getting a narrowing pulse pressure, this patient is past critical. They are super critical, and you don't want to get them to that point. I think that's probably one of the reasons you don't want to memorize things. You need to understand what's going on.
Can you go back one slide?
Also, I'm sending pictures.
Oh.
I'll send you. They're my group.
You have a question?
I just wanted to go back one slide.
Do you want me to go back one slide?
I wouldn't mind that either.
You ever seen this, Jeff?
Huh?
You ever seen this? Pericardial tamponade, you ever seen it?
Do I have what?
Have you seen
No.
it?
Have I ever seen
You're not
it?
the 213 or the 318?
I saw them at the
I like
hospital.
this group.
Are they dead?
No, I was out of surgery, guy came out of surgery and they actually had a valve, they left the valve in so they can continue to pull the
Oh,
valve.
wow.
It's very fascinating.
Yeah, no, I've never seen anything like that that I can remember.
Yeah, it sucked to be him, but it was very fascinating. The guy lived. He did. He had open heart surgery and then,
Do you get tracheal deviation in a pericardial tamponade?
No.
No.
why not?
Because it's fluid, it's not
So,
gonna push against.
it's not pushing either direction, right? It's just pushing in on the heart. It's inside the pericardial sac and it's pushing on the heart as opposed to a lung pushing everything over
Oh.
in a tension pneumo.
Sucking chest wound?
Mm-hmm.
That's one's not hard. How can you tell if there's a sucking chest wound?
Big old hole.
There's a hole in your chest and it's making a sucking noise.
Sterilizing, sterilizing.
All right? Or bubbles are coming out of it. Remember the crackling when we saw the subcutaneous emphysema?
Yeah.
The Rice Krispies? And that indicates air is getting underneath the tissue. It's escaping from the airway. It's due to a rupture or something like that.
Did I show you guys the goat lung?
Yeah.
Yes,
Yeah.
That's
a few times.
Yeah. Experts on the go.
Okay, so you put on the occlusive dressing and the patient starts getting worse, what do you do?
Take it off.
Take it off. Do you put it back on?
The same one.
Depends if they get
But
hurt.
there's no rule one way or another.
Yeah. I guess you would, so like on the long ride, if they're getting worse, you take it off, and then if they start getting better, you put it back on?
You don't have to put it back on.
Oh, you can never, you don't have.
Yeah, I mean, can you live on one lung?
Yeah.
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 So,
Yeah, he likes in the sun, but yeah,
I mean. not
What's that?
he likes in the sun, but
It
yeah.
can be difficult.
Extraordinarily amount of pain.
All right. Which injury does not get a dry sterile dressing?
The
Evisceration.
Evisceration, very good.
damn it.
Which gets what?
Wet sterile dressing.
Was the,
Uh-huh.
Yeah.
Over the evisceration, and then what goes over
and
that
then you like
dressing?
a dry, a big.
An occlusive dressing.
Oh.
Ooh, I didn't know. No.
Then what goes on top, I'm sorry?
Huh?
What goes on top of the wet sterile dressing?
Occlusive.
Occlusive, okay.
That's a dry sterile dressing.
Okay, dislocation, I don't know that there's anything particularly earth-shattering about this. Just remember when to realign, when not to realign. And the same is true for fractures.
So if they have CMS, you would never try and realign?
No, there's no necessity to do it, but.
Okay, even if they're in extreme pain, you think maybe, no?
No. Realigning isn't gonna decrease the pain. Yes,
So is the point of realigning just to like return the circulation?
it is. A, amputation and eyes. Amputation, basically, you get the amputated part, put it in a dry, sterile dressing, take the dry, sterile dressing, put it in a baggie, float the baggie in cold water. Eye injuries, remember, you put very little pressure, if any, on the globe of the eye. Inside the eye is a jelly-like substance called vitreous humor, and if you put pressure on it, that stuff will come out, and then the eye has to be removed. Also remember to cover both the affected eye and the not affected eye.
And if there's something in there, keep like,
I'm sorry?
if there's something in it, then just make sure it's secured.
Stabilize, don't
Stabilize it,
pull
yeah.
anything out.
What's the reason for that again?
I'm sorry?
What's the reason for that again? Covering both eyes rather than just one?
It keeps, if you cover both eyes, the eye doesn't move, they don't move as much, and if they move and there's something in it,
Oh.
damage it. Burns, remember to stop the burning process. Sterile dressing on top of the burn. Burns to the eyes, irrigation, minimum of 20 minutes. And if you suspect a pulmonary burn based on damage to the face, soot in the mouth, missing or burnt off facial hair, you need to put the patient in a semi-Fowler's position. Watch for and treat pulmonary edema. Watch for and treat wheezing. Huh? Yeah.
Can you go back to the last slide, the eyes?
Okay, somebody's exposed to a toxic material. If it's a liquid, you flush it off, remove affected clothing. If it's a solid, remove affected clothing and brush it off and then irrigate it. Okay, so you've got a patient in a vehicle accident. They're not slumped over the steering wheel, but they've got stertorous respirations. What do you need to do? Alpha, Bravo,
B,
I'm sorry?
I think.
B.
Alpha?
B.
Okay, you guys seem totally oblivious to this one. You're inside a vehicle, you're snoring. What needs to be done?
C.
Okay? We're not gonna apply a cervical collar. It's not opening the airway, is it? And if I open the airway and then I have to move them out, what do I have to do again? Open the airway. So let's get them out of the vehicle and then open the airway.
I'm reading that as a motorcycle.
You guys saw the answer in the first slide, remember, or the first few slides, emergency extrication. Airway was a reason to rapidly remove the person. Go back to the ABCs and know when you rapidly extricate versus when you've got time to extricate. Okay, 36-year-old female is unresponsive, abnormal breathing, bilateral ecchymosis, battle sign. What do you think? Okay, you need to use
Crom.
phonetics.
Crom.
Crom. Absolutely.
Yeah.
Okay, it is a basal skull fracture. How do I know that?
Vital signs and
That's fast.
variable ecchymosis.
Yes.
That's what Debbie will.
You got classic. Classic. Okay. Patient was hit by a baseball bat in the belly. They've got a lot of pain. They're pale and sweaty, alert and oriented. What other sign of shock would you expect? This is a critical thinking question, not a memorized question. You've got to know what the body's going to do.
Alpha?
You really think their blood pressure is going to go down and they're alert and oriented? Crom. You think their heart rate will go down as a result of an internal
It has
bleed?
Delta.
Huh?
Delta?
B.
Yes.
Oh my God.
Radial
I don't know
pulse.
this one.
Tachycardia, D as in David. Okay, you won't lose your radial pulse until you begin to go into decompensated shock. Yes,
So is that because he's trying to make up for
remember when pressure goes down, what does the body do?
beat fast?
You got it.
Oh, okay.
That was right from ours. What was
That's
it?
why memorization
What
of this
pressure
stuff
was that?
really doesn't work.
Because lack of
I would
oxygen.
apply that one.
Okay, you've got a patient with a tourniquet to their right arm. What else should you do? Yeah, I think this one's pretty self-explanatory. I mean, you never release a tourniquet, so we can get rid of B and D. And do we ever put ice on that type of injury? No, so I mean, ultimately, the only answer that would work, and it's the correct answer, is treat for shock, which is A. Okay, penetrating chest trauma, stabbed, patient is hypotensive, absent left lung sound, shortness of breath. What do you think?
B.
Bravo.
B.
Bravo.
Bravo.
Everybody okay with Bravo?
Yeah.
All right, and the reason it's Bravo, because it can't be any of the others. Question?
No, I was scratching.
Oh, scratching,
Yeah, scratching.
okay. Okay, arterial bleed, patients in shock, what type of shock is it?
Delta.
Yeah, delta, that is probably the easiest question you're gonna find. Okay, wow, where did this one come from? Patient was kicked in the chest by a horse, and they've got tachypnea, it hurts to breathe, both lungs are clear, they're walking, what should you do?
B.
Alpha.
You
Wait,
really
wait,
think-
wait. I didn't read it.
B. Bravo.
Yeah.
Bravo, bravo, bravo,
Yeah.
bravo, you got it correct. Now you're thinking like EMTs. Okay, when we look at the factors involving energy and injury, what is the primary factor?
Delta.
Speed. Speed kills. Velocity. I will hand this over. I know that some of you may want to copy this stuff. There you go. Any other questions? Nobody asked me how Cron was.
How's
I am
Cron?
heartbroken. Oh my God, Cron will not, he's gonna be pissed.
Don't tell him about this.
Huh?
Don't tell him about
I won't. I won't. Yesterday, he was being Mr. Lovable.
Oh, really?
No matter where I walked, he wanted me to carry him. Sitting there holding a 15-pound cat like a baby. And it's like every place I go, if I put him down, he sits and meows and bites. And if I hold him, he's happy.
How old is Cron?
6.
It's good exercise.
Yeah. Yeah.
Pick up the cat, you put him down. You pick up the cat, you put him down.
Cat push-ups.